Good evening. Namaste everyone for another CCA webinar Thursday, well known for that. So Thursdays are well known since last 4 years and 4 months regarding CCA webinars. And today's webinar is very special in so many reasons. Actually, today we planned with a few other people due to their last moment issues like which genuine issues. So they couldn't join, and all of a sudden, I wholeheartedly thank our Chennamchetty webinar coordinator who took everything upon him. Like he is now the moderator, he is now the topic master, everything. But I'm not much worried because I have such a wonderful panel here. Well, this webinar heading tomorrow is, the header is Beyond Pulmonology for Pulmonologists. So this is my idea, this header, the concept is my idea. So this actually goes in such a way that, see, whenever a patient comes to you for the treatment of any respiratory illness, let it be bronchial asthma, COPD, it is not a verdict that it is having only that illness and nothing beyond that. So the people who arrive, they are also having maybe having diabetes mellitus, they may be having hypertension or IHD or any other cardiac issue, or the patient could be having any other system related illness which is on taking regular treatment already on. It could be CKD for that matter. It could be some hormonal illness. So all such things. So when the patient comes to you, basically, you don't tell him like, hi, namaste. Okay, I'm here to treat you for the respiratory illness. What you do is, sir, I'm taking these pills for diabetes and hypertension and all that. He approaches you. And I don't know, I have observed this. A few of them, they don't even see that. No, it's okay. It's okay. You continue it. I will take care of my part, that is respiratory. You can continue with that. So for two things, you should look at these pills which the patients will come and show it to you are the previous doctor's prescription. First is, it will build confidence in them that this doctor knows my overall condition. Now I can completely trust him. That is one thing. And second thing, when you tell him, okay, for diabetes and hypertension, you can continue these medications. After looking at them, then he'll feel more confident. Yes, doctor has seen this. It is not only the beta blockers, it is also the calcium channel blockers, which are worrisome at times in respiratory that we have to always think of. Even the class of we call as inhibitors, ACE inhibitors, although they are very comfortable, we should also see to it that whether it is combined with any other drug along with that, so that it becomes not suitable for a respiratory patient to take. And now coming to other aspects, like there are so many things like malingering in school-going child, for which you cannot just tell that this fellow is acting, just take him home. You should do something to him. If your counseling doesn't help, then you should always refer him to a psychiatrist. So such a network is essential here. Now coming to today's panel initially, so that I continue my talk before that, we have a brilliant panel here. We have Chandrakant Tarke from Hyderabad, who is in Apollo, and he is one of our long-standing CCA life member. Welcome, Chandrakant Tarke.
Thank you, sir.
My lovely Bahan, she is brilliant in everything. She is known in the entire Maharashtra for Zumba, and people know her regarding Zumba and pulmonology. So that is something called Zumbology. So she is very well known for that. And she's also very intelligent and highly academically oriented. Now coming to Gagan, Gunjan, Thakur, Namaste. So we are blessed to have one MD General Medicine here and one MD Internal Medicine here. So one internist and one generalist are there here. So both of them, they will help us beyond pulmonology. With this for pulmonology, we have Chandrakant Tarke, and already I quoted regarding him. I don't hesitate to quote it again. Chennamchetty, not only our CCA webinar coordinator, he has been the mainstream in CCA webinars framing, doing a Zoom meeting prior that. So hats off to him. We have two other specialities who are also CCI honorary life members. We have my Bahan, Dr. Shilpi Doshi from Indore, who happens to be Dr. Ravi Doshi's wife. He's a favorite always. So she's our consultant for this webinar for as pathologist. Now I come to Nikhil. Namaste, Nikhil. Nikhil happens to be our all-time radiologist, and Nikhil is Kirat's husband. So it's all a family feeling here that we know you and we know your family, everything. Now, coming to today's topic again. So I was telling initially, now we have internal medicine person, we have physicians with us who are into pulmonology also. Their role today in explaining things when patient comes to you is also vital. Now, the relation between a radiologist and a pulmonologist is very important. You should have a very good radiologist friend. You should have a very good pulmonologist friend whom you can call, talk, discuss, and can see. I'll tell you, a phone call is more ideal to speak than just looking at the reports. So you can ask, or even before sending, you can tell that I'm suspecting this. Can you please dwell further in this? So that will be easy for the cross specialties also. Coming to the rest of the systems getting involved whenever we are treating pulmonology, Chennamchetty has made such a huge list that if I keep talking like this, such important aspects could be missed. So here today, I hand over this to Chennamchetty, who is both the moderator and topic master today. He will be running this webinar, and I'm very sure, like any other CCA webinar happening till date, this will be a super hit, and more than that, it will be a mega hit. Thank you, everyone.
Thank you, Anna. Thank you, Anna, for that wonderful introduction and highlighting such a unique thing that sometimes many people believe that to achieve success, we have to do really big things. It is not so. We have to do small steps, corrective steps. Small things will give us a huge impact in patient's life. So that is what is today's webinar is meant for. Those delegates who have logged in. So my suggestion is please do not hesitate to ask your dilemmas to our esteemed panelists today. Please post all your queries so that we'll discuss in depth till 10 p.m. And I would also request Krishna Anna to do this topic in much more probably as to recall Bahubali 1, Bahubali 2, Bahubali 3, like this. So we have to, beyond pulmonology for pulmonologists, should be, come in a series kind of thing. Because past 1 week, we really, entire panel strived really hard to work on this webinar. And then yet, there is so much of concept to cover. It has become really, we could cover, probably we can cover only to certain extent. I request Krishna Anna to continue this series for at least 3-4 series, so that we'll divide into individual system and then we will execute this unique concept. And
completely agree.
Thank you, Anna. Thank you so much. And bye-bye, Anna. And apart from whatever Krishna Anna said, so what's happening in this modern world? The interaction, the rapport that we create with patients, and if we write some investigations to our patients, some may feel that this doctor is being over-investigating. And if you write less investigations, what we feel personally is probably I may be missing some important points, so that, there may be some vital issues I may not be covering while evaluating. So medico-legally also, we are answerable at the end. So that's why there is a gray zone. So This I label it as a Lakshmana Rekha. When to cross Lakshmana Rekha or not. This Lakshmana Rekha, okay, is a gray area and it is very, very important. Today in our session, we'll discuss such beautiful cases as well, so that the importance of this gray zone and how to tackle in such scenario, we will have it. We will have a thorough discussion with our esteemed panelists. And without further delay, I would request both Gagan Gunjan followed by Dr. Vrishali to talk on pulmonary manifestations of systemic illnesses and systemic manifestation of pulmonary illnesses. Over to you, Dr. Gagan.
Good evening to one and all. I thank at the outset Chess Council of India for providing me this opportunity. And the topic given to me for today is pulmonary manifestation of systemic illness, a bird's view. So moving ahead, to introduce you with the topic, systemic diseases are those that affect organs and systems in the body, including the respiratory system. In this context, we will outline various forms of systemic diseases which impact lung performance and how they occur and all forms of pulmonary compromise that they present before us. So systemic illnesses can significantly impact lung function and structure. Common diseases that are affecting lungs include autoimmune, hematological, and endocrine disorders. Pulmonary manifestations vary from mild respiratory symptoms or signs to severe fatal disorders. So if you look at the pathophysiology, then systemic diseases affect lung function in the following ways. Now, what are these systemic manifestations that can happen? They can affect the lung by causing general inflammation, autoantibody synthesis, and vascular changes. Systemic diseases also involve the blood vessels that can lead to pulmonary circulation and gas exchange problems. Common symptoms that often present or of pulmonary involvement in systemic illnesses are dyspnea, chronic cough, and chest pain that is especially pleuritic but may be related to inflammation or even fibrosis. Dyspnea is a frequent symptom ranging from mild to severe, whereas chronic cough is often dry and non-productive and may indicate interstitial lung involvement. So if you look at the diagnostic approaches, then what are the diagnostic approaches that can be helpful for us in a case of a differential diagnosis that we can often come across pulmonary diseases or certain manifestations? The assessment of pulmonary involvement in systemic disease employs a rational approach. These are CT scans of the chest, pulmonary function test, and serological testing that is quite valuable in identifying autoantibodies related to lung manifestations. If we look at the classification of pulmonary manifestations, then there are several ways of categorizing pulmonary manifestations in systemic illnesses. These include interstitial lung diseases, including various patterns of fibrosis and inflammation, or it may be airway diseases such as bronchiectasis and bronchiolitis, or it can be either vascular disorders, including pulmonary hypertension and vasculitis. If we look at pulmonary manifestations in autoimmune diseases, then pulmonary manifestations are quite common, and it may be in the form of the interstitial lung disease that is a common complication in various autoimmune conditions, or pleural involvement, including effusions and thickening, frequently occurs. Pulmonary vascular disease can lead to pulmonary hypertension in some autoimmune disorders. Then we have rheumatoid arthritis and lung involvement. Rheumatoid arthritis can cause various problems in almost any part of the body, including the lungs. They comprise of interstitial lung disease, that is a significant extra-articular manifestation of rheumatoid arthritis, or it may be in the form of rheumatoid nodules that can develop in the lungs, sometimes causing pneumothorax, or it may be in the form of bronchitis and bronchiolitis that are common airway complications in rheumatoid arthritis. SLE is known to have an impact on different structures of the respiratory system. It is widespread, and pleuritis is the most common pulmonary manifestation of SLE. Acute lupus pneumonitis can cause rapid onset respiratory failure, or it can be in the form of shrinking lung syndrome that is often characterized by diaphragmatic dysfunction. And it is for this reason that it is important to identify these manifestations. Coming to the vasculitis part, vasculitis frequently affects the pulmonary system with manifestations which include pulmonary hemorrhage and granulomatous inflammation. The patterns of lung involvement help in differentiation of various vasculitic disorders as well as in their management. Granulomatous inflammation in the lungs is characteristic of certain vasculitis, whereas pulmonary artery involvement can lead to pulmonary hypertension and other complications. If we look at the Wegener's granulomatosis, it is mainly characterized by upper and lower respiratory tract involvement, along with polyangiitis. Pulmonary nodules, often cavitating, are a hallmark radiographic finding. Diffuse alveolar hemorrhage can also occur, and it may be life-threatening often. If we look at the pulmonary manifestations in connective tissue disease, then ILD is a common and often severe complication in many of the diseases. Pulmonary arterial hypertension can develop, particularly in systemic sclerosis and mixed connective tissue disease. Pleural involvement, including effusions and fibrosis, occurs in various connective tissue disorders. If we look at the systemic sclerosis and ILD, then systemic sclerosis often presentation is finger thickening and Raynaud's syndrome, along with telangiectasis. Scleroderma interstitial lung disease is one of the most significant sources of morbidity and mortality in those affected by the disease. Non-specific interstitial pneumonia is the most common pattern of ILD that is seen in patients with systemic sclerosis, and periodic examination and prompt treatment are the only ways that are necessary for the treatment of ILD in patients with such conditions. Hematological malignancies can trigger pulmonary edema and hemorrhage. The risk of thromboembolism is increased in many hematological diseases. Pneumonia is commonly seen due to an impaired immune system in hematological disorders. Acute chest syndrome is a potentially fatal condition associated with sickle cell disease. It is associated with chest pain, fever, and new pulmonary infiltrates. So, acute chest syndrome has causes such as vaso-occlusion, infection, and fat emboli, and early identification and good management are vital to reducing morbidity and mortality. Similarly, if we look at the pulmonary involvement in endocrine disorders, then it can be either primary or secondary in origin and is a common manifestation of endocrine disorders. These effects include changes in lung volumes and increased susceptibility to infections. Studies have clearly indicated that thyroid or disorders often affect respiratory muscle strength and lung capacity. Diabetes mellitus can lead to compromised lung capacity, and those with Cushing syndrome can also affect the respiratory muscle weakness and a higher tendency to have secondary infections. Similarly, if we have some of the microvascular complications in relation to diabetes, then it can include impaired lung function with time, and patients suffering from such diseases are often susceptible to respiratory infections and complications. If we look at the treatment approach, then we have very, very multidisciplinary approach has to be taken up. Pulmonary manifestations that occur in systemic illnesses need to be addressed holistically. This involves managing the primary cause of the LRTI, managing the specific lung diseases, and supportive care. This underscores the need for tailored treatment plans to achieve the best results. Immunosuppressive medications are often applied, and especially when dealing with autoimmune-associated lung conditions or involvements. Ambulatory care, supplemental oxygen, and pulmonary rehab interventions have a good outcome. If we look at the monitoring and follow-up plans, then we have routine spirometry tests, serial imaging aids that help in determination of structural changes, and then regular clinical examinations that often help in the early identification of emerging or worsening lung conditions. Then, prognosis varies widely depending on the specific systemic illness and type of pulmonary involvement. The intervention at the early stages can change the situation in many cases, and long-term management is considered to be complex and frequently necessitates the involvement of pulmonologists, rheumatologists, and other professionals as well. Now, if we look at the future directions and takeaways points, then here the skills of evaluating and diagnosing pulmonary manifestation in systemic diseases are central in the management and care of patients. With continued scientific advancement, better targeted individual treatments, and improved strategies aimed at management of the disease will be developed, thus benefiting those patients who are affected, and a systematic approach to diagnosis and management and ongoing research is needed to develop more targeted therapies and improve long-term outcomes. That's all. Thank you so much.
Very good evening to all my colleagues, and thank you, Team CCI, for once again getting me on one of their webinars. And it is a topic close to the heart again, because I believe that as a pulmonologist, I should not only look at the lungs, but to the patient as a whole. So I will be discussing about the systemic manifestations after you've heard my colleague discussing about the pulmonary manifestations of systemic diseases. And let me tell you that, in these, you have very few things which you need to know. That is, most of the times the patient will have symptoms which are related to anoxia or hypoxia. They can be because of CO2 retention, a right heart failure. Systemic inflammation can give rise to almost an increased risk of every other organ system besides the pulmonary system. And there can be presence of right heart failure, as I just told you. So this slide just shows you in short that, if you watch the skin carefully, there is erythema nodosum. This is TB involvement of the skin. All of this will be seen in SLE. In this feature, you have sclerosis or scleroderma, which is seen left. A DVT, which points to a pulmonary embolism or infarction. This is the myositis profile, where you have the dermatomyositis kind of thing, plus presence of osteoporosis, which will come as weird bone pains for these individuals, which can be because of the disease or it can be because of the treatment of the disease. Anxiety and depression is something which you see, because sometimes that could be responsible for the pseudo worsening of the patients, or that is one symptom or sign which is left untreated. And patients may have symptoms of mild cognitive impairment, as in most of the chronic respiratory conditions as time progresses. This mannequin kind of shows you from head to toe what are the things you need to see in your patient who presents to a respiratory OPD or maybe the indoor patient setup. So presence of encephalopathy, Horner's syndrome, dilated collaterals. So the dilated and Horner's can be in favor of lung malignancy. Encephalopathy because of cerebral anoxia, can be because of CO2 retention. It can be because of the septic or the metabolic encephalopathy. Cervical lymphadenopathy in tuberculosis, malignancy and metastasis. You can have the presence of heliotrope rash, malar rash, fish mouth, taut skin pointing towards a connective tissue disorder, thyroid enlargement, and you can think in terms of retrosternal goiter for patients who are presenting with dyspnea or they have an inspiratory stridor. Loud P2 in most of the chronic cases, which can lead to a right ventricular failure. Hepatosplenomegaly, then abdominal lymphadenopathy, pathologic fractures. These can be seen, pathologic fractures, particularly in the lung malignancy, and the HS megaly and lymphadenopathy can be in tuberculosis. It can be seen in lymphomas, in metastasis, presence of ascites, again in all three. Warm extremities, bounding pulse, think in terms of CO2 retention, muscle wasting, all chronic conditions, calf tenderness, unilateral leg swelling. There can be an edema, a DVT in that side, and then again points towards an infarct or an embolism in the lung vasculature. Presence of the erythema nodosum can be in tuberculosis. It can be in sarcoidosis as well. Migratory thrombophlebitis in lung malignancy. So basically, now we'll go the disease-wise. So commonly seen disease at our end is COPD, and that a serious COPD is a pro-inflammatory state. So the cigarette smoke elsewhere and in Indian setting, the non-smoking COPD, there is presence of inflammation in the lung which spills over into the system, and that can lead to release of various inflammatory cytokines like interleukin-6, interleukin-1 beta, TNF alpha, leading to an increased risk of ischemic heart disease, cardiac failure, osteoporosis, diabetes, then metabolic syndrome, normocytic anemia, and depression. There can also be presence of skeletal muscle wasting, and there can be cachexia seen in such individuals. Plus, you have to keep on looking out for signs, for symptoms as well as signs of lung malignancy in these individuals. Tuberculosis, we commonly know the most common symptoms, which also match with that of lymphoma. But in addition, you have to be vigilant whether there's involvement of the CNS in terms of headache, vomiting. There can be abnormal neurological findings. There can be enlarged lymph nodes, so extrapulmonary tuberculosis. There can be the presence of a pericardial rub. There can be enlarged lymph nodes, abdominal pain. There can be ascites. There can be presence of diarrhea, rectal bleeding, where you should think in terms of the abdominal tuberculosis. There can be urinary symptoms to point towards genitourinary tuberculosis. And in females, an infertility should point or should help initiate a workup for tuberculosis of the reproductive system. Community acquired pneumonia, so many times the patient really doesn't come with features or of cough or breathlessness, but rather the elderly people come with fever, chills, fatigue, malaise, and they come with features of altered sensorium, can have tachycardia and hypotension at the initial presentation, and eventually we find out that they have a lot of other organ dysfunction. Pulmonary hypertension, extremely busy slide, but what I mean to tell you over here is that each lung condition or each pulmonary condition actually affects all organ systems, and we need to know about them. So in short, over here in the eyes, you can have opal angle glaucoma, there can be retinal detachment. Thyroid, you can have both hyperthyroidism. Liver, there can be hepatopathy, congestive kinds, and chronic-ish thing can lead to a cardiac cirrhosis. Iron homeostasis being affected, there can be anemia, there is diabetes, systemic inflammation, I think in all conditions, autonomic dysfunction leading to increased risk of syncope and arrhythmias. There can be a left heart dysfunctional, which can be systolic dysfunction, which can be systolic or diastolic. Gut and bowel, there can be leaky bowel syndrome and malabsorption, and further change in the gut microbiota, which increases the systemic inflammation, skeletal muscle deconditioning. So I think I'll skip this. Basically, what we will need to find out is this manifestation a cause, is it an effect, or is it both? But largely what you need to remember is that we need to see these because this is important for us as long-term follow-up. Maybe we are just following up the pulmonary hypertension, the other things could be worsening. Lung malignancies, typically some things which you need to know is that the patient can come with just dysphagia, back pain, they can come with a pathologic fracture, and you might find that, superior vena cava syndrome, there is presence of the edematous neck veins and the pharyngeal edema. So in the cartoon on the right, and in a patient of Pancoast tumor, you will see the presence of Horner syndrome on ipsilateral side, wasting of the hand muscles on that side. Patient might present completely with extrathoracic metastatic symptoms that is abdominal pain, jaundice, and weight loss. They can also come with non-specific symptoms. They can come with metabolic symptoms like Cushing's syndrome or SIADH. They can present with migratory thrombophlebitis. They can come with clubbing or pulmonary hypertrophic osteoarthropathy, and they can come with neuromuscular symptoms in terms of subacute cerebellar degeneration, encephalomyelopathy. Interstitial lung disease. So in RA, you suspect an RA if you have features, you see the patient in toto where there's a lot of arthropathy, they have symptoms of early morning stiffness. There can be other system involvements as has been mentioned in this graph. And on the systemic lupus front, this is more where you see patients with butterfly rash. There can be ulcers, aphthous ulcers in the mouth and nose, and they can present with they can give you a history of hematuria, and they can have joint aches as well as swollen joint. I remember I was called in to see one patient of pregnancy to start AKT, but the moment I saw her malar rash, I asked for a urinary result, which was done, which was not seen, that she had 3+ hematuria, and we eventually diagnosed her as SLE and not tuberculosis. Systemic sclerosis, I think this is one of the things where you have maximum findings in terms of telangiectasis. You have the presence of digital ischemia, Raynaud's phenomenon. There can be skin thickening, scleroderma, calcinosis, and there can be musculoskeletal involvement, including contractures in the hand. In sarcoidosis, I think this is one of our differentials for tuberculosis, and you see that there are a host of things. So ocular is what we might or might not see, that there can be conjunctivitis, which can be seen by us. But largely what we can see is erythema nodosum. There can be lymphadenopathy, there can be some kind of myopathy. Nervous system, typically there can be presence of the 7th cranial nerve affection, though it can affect any cranial nerve. These patients can present with seizures. There can be hepatosplenomegaly, and there can be, once you do the other examinations, you will go towards sarcoidosis. Dermatomyositis, polymyositis, these usually come with proximal muscle weakness more than the distal muscle weakness. In cardiac, you can have the patient coming with arrhythmias or congestive heart failure. In the skin, you can see Gottron's papules, which are usually seen on the extensors of the hand. There can be presence of the Scholl sign, which is usually seen around the neck, heliotrope rash, which is seen around the eyes. There can be generalized erythroderma, periangular erythema, and there can be mechanic hands, and there can be calcinosis cutis. Bronchial asthma, again, one of the common things where the patient comes to us and doesn't really have spasm at that point in time, but there could be soft pointers in terms of there can be conjunctival congestion and inflammation, ocular shiners, and this is the kind of rash which can be present around the eyes. They can have a nasal crease, which points towards the reason that they rubbing their nose all the time. The nasal mucosa can be pale and violaceous. The turbinates may be hypertrophy. There could be presence of polyps, and you can have other features like urticaria. There can be eczema and atopic dermatitis. Obstructive sleep apnea and hypopnea syndrome. Now, this can come as where you suspect is very classical, in patients who have retrognathia. There can be micrognathia. When you look at the Mallampati score, a person who has a large neck, who is centrally obese, possibly has enlarged tonsils, who can have some nasopharyngeal abnormalities. If they have congenital or genetic factors like Down syndrome, there is structural upper airway disorders, and patient has medical conditions like acromegaly or hypothyroidism. But you should also suspect if the patient comes with unexplained fatigue. They can come with non-restorative kind of sleep. They can come with motor vehicle crashes. They can come with just cardiac conditions, in that they can have congestive heart failure or present with some kind of arrhythmias. Metabolic disorders, it can be just a diabetes mellitus, which is uncontrolled, a hypertension, which is uncontrolled. In obstetric and perinatal, you can have preeclampsia, gestational hypertension in these individuals, and have low birth weight babies born. In pulmonary, you can have patients whose asthma and COPD is somehow not getting controlled, and they have an additional element of obstructive sleep apnea hypopnea syndrome. And this is also a reason for post-surgical complications, where the patient is not being weaned off the NIV. So in summary, what I need to tell you is that extrapulmonary symptoms may be the only presentation, and we need to be aware of them, and we need to look out for them. Also, at the same time, once we've diagnosed a pulmonary case, we also need to know what are its associations, systemic associations, because that is as equally important for monitoring and treatment of the patient. Lastly, I shall tell you that, I always believe that irrespective of whatever specialty we are from, we should examine the patient as a whole and not keep the cardiac stuff for the cardiologist or the endocrine stuff for the endocrinologist. Thank you so much.
What a wonderful talks by both Dr. Gagan and then Dr. Murali. Dr. Gagan, I'm sure I can say confidently you don't appear like a pure internal medicine specialist. You appeared like in your talk like as a pure pulmonologist, with some background in internal medicine. So fantastic talk. I thoroughly enjoyed your talk. And coming to Murali, so as Murali, she did absolutely amazing. And then it's like she didn't like felt like she's a pure practicing pulmonologist. She appeared as a practicing internal medicine specialist. I'm sure all our delegates have completely enjoyed today's talk of both of yours. We are really proud of you. Without wasting time here, I would like to share my screen to start some interesting case discussions, and then followed by few questions we'll take from the delegates. My dear friends, whoever have logged in the webinar, okay, please make sure you post your questions, and I'm very happy to take the expert opinions from here. And one moment. Right. Hope the slides are audible, visible, and then I am audible, right? Right. Thank you. This is one 58-year-old male who is an alcoholic, chronic alcoholic, presented to emergency room with progressive dyspnea since past 1 week, along with fever and anasarca. On examinations, patient saturation improved on lying down, and on sitting up, he is desaturating by 3 to 4%. Ultrasound abdomen showed ascites and cirrhotic liver, and his ABG shows a PaO2 of 45 mm of Hg. He was placed on oxygen, following which there is a mild improvement in PaO2 levels, and chest X-ray and CT image is shown here and is as follows. This is some, as per this X-ray, which shows there is a lower zone and middle zone predominant reticulonodular shadows, predominantly reticularity, and then in the CT, which shows the prominent interstitial markings with some very mild pleural effusions. I can say some amount of pleural thickening kind of thing, with apparently some degree of some cardiomegaly is visible. And Coming to my dear good friend and colleague, we work at the same hospital, Dr. Chandrakant. Chandrakant, welcome to you once again. And then what is the most likely clinical scenario we are discussing here?
As we are seeing here, the patient is alcoholic and the liver involvement is there with the high INR. And most probably the patient is having some chronic liver disease. And considering the lung involvement with the hypoxia, most likely diagnosis is a portopulmonary hypertension in this case.
Right. So, can you Vrishali, is there any way that we can grade the severity of the disease depending on alveolo-arterial gradient and PaO2 levels? Please unmute yourself, Vrishali.
So generally, we know that the normal AA gradient is anywhere up to 15 millimeters of mercury, and if this gradient exceeds the 15 and sometimes even taken as more than 20, based on whatever is your PaO2. So if it is more than 80, it's between 60 to 80. It is 50 to 60 and less than 50. We can grade them as mild, moderate, severe, and very severe. Now, basically, in this grading, really. It just gets us a time frame for which, how you're going to plan the patient's treatment. This is going to be just oxygen, or you can put the patient on some somatostatin or its analogs, or you have to straight away push the patient towards a liver transplant, because that is the only treatment for these patients who develop a hepatopulmonary syndrome. So, the pointer towards what you said was that in the supine position, the saturation improved. Any other place where you have the more common cause which we see is a hepatic hydrothorax, really. And in that case, it would have really worsened. So Chandrakant put up very well that, he picked up that point that the saturation is actually improving in the supine position. That means it is worsening in the sitting up position, which is known as orthodeoxia. And that is a feature of hepatopulmonary syndrome.
Thank you, Vrishali and Dr. Chandrakant. And here, I would like to take your inputs, Vrishali. What is, in such scenario, what is the gold standard investigation to differentiate such a hypoxia from intracardiac stent, and how do you do that?
So basically, that one subtle pointer, that the supine to sitting up or a standing, where the oxygen has to drop by 4 millimeters of mercury, or a 5% drop in the oxygen levels. So you can see on blood gas, which can be done, and then you follow it up with a bubble contrast echo. In this, what is done is an agitated saline is given rapidly, and generally in a normal individual, this saline, the bubbles, they do not make past the pulmonary vasculature. But in patients who have shunt, now whether it's at the cardiac level or like we were discussing in this case, there are the pulmonary AV malformations. In these, you start seeing them in the left side of the heart. So generally, if you start seeing them within the first 4 cardiac cycles, it is an intracardiac shunt. And if you start seeing them between 5 and 7 of the cardiac cycles, it is a pulmonary shunt, which can be because of a condition like a hepatopulmonary syndrome or pulmonary alveolo-venous malformations.
Beautifully summarized. And how to, again, coming to Dr. Chandrakant, so the other differential what we come across is portopulmonary hypertension, and it is very, very subtle, very important as well to differentiate the HPS and then portopulmonary hypertension. What are the clinical clues, and how we clinically take these cases to differentiate both, and what is its clinical significance, Dr. Chandrakant?
It's very important to differentiate between the portopulmonary hypertension and other causes of hypertension, pulmonary hypertension. Basically, in both of the cases, there will be dyspnea, but in hepatopulmonary syndrome, we have the bradypnea. And portopulmonary hypertension, we get along with the dyspnea, the lower extremity edema, abdominal wall distension also will be there. We can get the clubbing in the hepatopulmonary syndrome, and cyanosis and spider angiomas and orthodeoxia. In portopulmonary hypertension, we have the increased JVP and prominent pulmonary component of the second heart sound. This will be there. And there will be elevated alveolar gradient in difference with the mild to severe hypoxemia in the hepatopulmonary syndrome. And this will be normal in the portopulmonary hypertension. These are the major differentiating factors between the hepatopulmonary syndrome and the portopulmonary hypertension.
Right. And is there any way that we manage differently these two cases, these two syndromes, Chandrakant?
Basically, we need to manage the underlying liver disease, that is most important, and
Yep.
supportive treatment.
Yes.
And basically, there are some studies we can give some vasodilators in the, especially anti-pH medications in the portopulmonary hypertension. But evidence is not concrete. But basically, we have to treat the underlying liver disease, and liver transplantation is the ultimate option.
Yeah, absolutely. Brilliantly summarized. What is very, very important is if the syndrome we are addressing is portopulmonary hypertension, and there is a role of pulmonary arterial hypertension targeted therapy. But if the same therapy is being given in hepatopulmonary syndrome, the clinical condition is going to worsen rapidly. So, my dear friends, please be cautious. And then when you come across a cirrhotic liver with hypoxia, please differentiate between HPS and portopulmonary hypertension and then treat accordingly. As Dr. Chandrakant clearly mentioned, it is very, very important to address the primary pathology, and also when the MELD scores are high, then you need to refer the patient for liver transplant as early as possible. And thank you both, Dr. Vishali and then Chandrakant. Now, I would love to take up to next case. This case, it's a 23-year-old male, about 55 kgs weight, and presented with complaints of severe left-sided chest pain, radiating to ipsilateral lung. On examination, hemodynamically stable, chest X-ray and ECG were as follows. I must tell you here, the additional information I want to give you is, this guy is a real case whom I have treated probably around 14-15 years back. This guy was in a breakup scenario, and then he was his parents were not allowing him to marry the girl whom he is in love with. So, and then he is neither with his girlfriend nor with his parents, and he was aloof, completely depressed, and presented with this scenario. And I would love to take the X-ray, chest X-ray inputs from Dr. Nikhil first. Dr. Nikhil.
Good evening, sir. Thank you for having me here. The chest X-ray here looks almost normal.
Saying normal is a very, very important task, to be honest, right? So Nikhil has confirmed that the X-ray doesn't give any information here. It looks absolutely normal. Now I would love to pitch in Dr. Gagan and then Dr. Chandrakant to give inputs on what is that ECG shows. Chandrakant, please.
The ECG, as you see, is clearly here. There is some ST segment elevation in V1, V2, V3, and there's some depression in the inferior leads. Definitely a clear-cut case of the MI, which is, I think, anteroseptal MI. In young, the tuberculosis or some pneumonia, pleural effusion. But as in this case, there is a classical left-sided chest pain with the radiation is also there, and stress factor is also there. So this might, this is definitely case of myocardial infarction, acute MI.
So only thing what was confusing me is his young age. But again, with the presence of depression and then aloofness, okay, so much of pain in his heart, okay, probably he would have thrown a STEMI. And then Dr. Gagan, you want to add anything for the ECG and chest X-ray here?
I agree with Chandrakant that what he has said. We can plan for thrombolysis and other things. More clinical history details are needed for that.
Right. So this is what we have done afterwards. The patient was thrombolized with tenecteplase. Next day, referred to angiogram, which showed 80% LAD stenosis, for which PTCA was done, and post-procedure vitus was stable. Now, here comes on POD1, patient developed hemoptysis. How to handle further? Vrushali, can you please pitch in?
Actually, post thrombolysis, having pulmonary alveolar hemorrhage in an otherwise person who was baseline normal is a possibility, though, I haven't heard about it, though it has been discussed. But generally, we would like to just conservatively manage. First, obviously, we'll repeat the X-ray. Most important.
Right.
Yeah,
Right.
we will repeat the X-ray. And if it doesn't show anything really, we think in terms of either there's a sources of pulmonary alveolar hemorrhage. The other thing is that sometimes there could be an occult bronchitis which the guy had, and after you've given the individual one of these thrombolytic agents, and now that he's undergone an angioplasty, he must be on a Brilinta kind of a drug, where you can have a subtle bit of cough and that can give rise to bleeding. So generally, I will like to go in terms of conservative in the sense, try to suppress the cough.
Right.
It also depends on what is the amount of hemoptysis.
Right. Right.
Yeah, if it's a mild of hemoptysis, we will just be observing the individual. We really can't take off the antiplatelets at this juncture.
Exactly.
Just with the flat
Exactly. Platelets remains,
Yes.
very crucial. We
Yes.
should not discontinue antiplatelets immediately in the post PTCA time. Right.
Yeah.
Absolutely.
Again,
Brilliant
to give
message.
and if to give these tranexamic acid and all these other hemostates is again fraught with their own problems, because we have a recent myocardial infarction, and we don't want to go into that zone where then we might increase the risk of restenosis in this individual, though that is not much known with the tranexamic acid kind of thing. It's much more with the removal or withdrawal of the antiplatelets. So largely it depends on what comes out. Antitussives is something I think I will go in for.
Right.
In
so
this individual.
Probably, if required, tranexamic acid is
a
what.
Little bit of Restil. His heart pain is too much, so
Right.
a lot of sedation or
Right. Probably morphine.
Yeah. Yes. So you have fentanyl currently. That
Right.
is the drug. Yes, definitely these things.
So coming to he started pouring out too much of blood. Chandrakant, okay, what do you do now? Being you are the lone pulmonologist and critical care specialist in this ICU. So how to manage if his hemoptysis persists, despite whatever Vrushali said, use antitussives, suppress the cough, and then use tranexamic acid, use morphine or fentanyl. All this we have done, but his hemoptysis is persisting. Do you want to go ahead and then stop antiplatelets, or do you want to refer to an interventional radiologist, or do you want to do our own measures? And please throw some light here.
Particularly in this case, the hemoptysis is likely due to as Madam said, yes, maybe alveolar hemorrhage, and maybe because of the thrombolytic agent. If it is a mild, I think we can leave like that. If it's a life-threatening, as you are telling, in this case, definitely, I think we should go ahead to the intubation for airway protection. And usually, life-threatening hemoptysis can occur because of there is underlying some lung disease, a lung cavity. And in that case, if the unilateral disease is there, we can isolate the one lung with the double lumen endotracheal tube. And in this case, I think X-ray was normal. But otherwise, in other cases, if there is a hemoptysis, we can do the bronchoscopy to find out the culprit lobe. And in that case, we can isolate that lobe with some picots or some blockers. And to find out the diagnosis, we can do the bronchoscopy and BAL also, if possible. And as you asked, the methods of isolation, the double lumen endotracheal tube is one of the option. And in emergency, we can do the rigid bronchoscopy to clot removal, and even we can isolate one of the lungs.
Yeah. More importantly, I just want to add one point, Chandrakant. If you start, unless unless the the blood which is spread across the both lungs. So it is better to not to do a rigid bronchoscopy and then try to extract the clot. So the more you extract, the more chance of bleeding persists. So that's why it is, as you rightly mentioned, it is very, very important to isolate the normal lung. If you have probably a patient who had a previous history of left side aspergilloma, left upper lobe aspergilloma, or some right side bronchiectasis, this particular side has to be blocked using either bronchial blockers or, as you said rightly, using a WMN tube, and then try to protect the normal lung so that we can continue to ventilate. And then after stabilization, probably we can hand over to interventional radiologists. And next case of doctor, I would love to have Dr. Gagan also here. So this is about a 55-year-old female, a case of bronchial asthma on regularly using LABA plus ICS, and also she was on montelukast and an antihistamine, presented to ER with severe dyspnea for the past 2 days. Her last exacerbation as per records were 1 month back, where she was managed at a different hospital with a systemic steroids, nebulized bronchodilators, and an antibiotic. On examination, it was noted that patient was having residual dyspnea despite on maximum bronchodilator. Her saturations were 85 on room air with a respiratory rate of 30, rest of the vitals being normal. Auscultation was reasonably okay with no added sounds, and ABG showed 85% on ABG showed 7.19 pH, PCO2 of 58, PO2 of 84 on with supplemental oxygen, bicarbonate of 29, lactates were normal. Blood pictures showed mild leukocytosis with eosinophilia. That also says that she is T2 high asthma, and AP view chest X-ray done shows follows. Will show the X-ray soon. Despite aggressive initial management, please note, despite the aggressive initial management, patient hypercapnia got worsened, and then the patient was intubated and placed on controlled mode ventilation, and immediately within next probably 30 minutes, 1 hour, we could bring down the FiO2s to 40%. P peak was assessed, P plateau was assessed, both were within normal limits. ABG was completely normalized, and as patient stabilized, CT scan chest was offered. Now, I would love to take the inputs of Dr. Gagan and Dr. Chandrakant here. What is that we are dealing with, Dr. Gagan?
It could be a case of paraneoplastic syndrome.
Chandrakant?
As per the history, it's having eosinophilic asthma, exacerbation type 2 acute hypercapnic respiratory failure, and with the ventilation, this ABG values are fairly optimized. Basically, it's acute exacerbation of the asthma.
Right. So we don't see Chandrakant, when we have intubated a patient of acute severe asthma, so we don't expect the airway resistance to be completely normal. Dr. Rushali is raising her hands. Rushali, over to you.
See, what I'm seeing is that she's a T2, she's a eosinophilic asthma phenotype. She has had a disease which is fairly uncontrolled despite, she's got 2 exacerbations.
Yes.
So in this scenario, like I had just discussed, these people have a lot of skeletal muscle wasting also. So neuromuscular should come into picture. Another thing is because of the breathlessness itself, she can go into fatigue and therefore the CO2 retention can occur. Thirdly, hypokalemia and hypomagnesemia come in. And fourthly, we saw that, COPD was another thing. There's an underlying COPD. And we always look out for other neuromuscular disorders in such an individual. So these are the 4-5 things which we should look for in an individual who apparently is being optimized but not responding as well. And of course, cardiac and other things come into picture. So whether there's an untreated heart failure and because of her, 55-year-old with an asthma, which has been quite severe.
Right. So many factors we need to consider, because again, my dear friends, please look at this scenario where a regular asthmatic, she was, despite being managed with good bronchodilation, so she is not able to be stabilized. So that is a scenario, as Dr. Murali rightly said, we need to look into other scenarios and other differential diagnosis. And now I would like to take the inputs from Dr. Nikhil. What is this was the X-ray, Dr. Nikhil. Okay. Can you please throw some light here?
In this chest X-ray, the main, I'll come directly to the main finding. There is mediastinal widening with lobulated soft tissue margins. And the lung fields are more or less clear.
Right.
So this could be something in the mediastinum, most likely a mediastinal mass.
Right.
So I would advise CT for further evaluation.
Right. Here is the CT of the same patient. Please add your inputs.
This CT shows a large lobulated mass in the interior mediastinum and a hypodense area in the middle of the mass. Could be necrosis. Doesn't look like fat though. So maybe a teratoma or a thymoma or a high-grade lymphoma post-treatment.
Right. So probably there was no lymphoma history. So we can post-treatment, we can forget about it. Probably a teratoma and probably a thymoma. How to say that, how to differentiate between a teratoma and thymoma in such scenario radiologically? Of course, I am going to soon ask Dr. Shilpi Doshi as well, how to differentiate histopathologically. So first of all, your inputs, how to differentiate in such scenario, Dr. Nikhil?
Teratoma generally has some areas of fat and calcification or some hair, teeth or something like that within. So it is a very heterogeneous mass. This looks like more like a necrosis. I have to be sure on a contrast CT though.
Wow. Right. Thank you, Dr. Nikhil. Definitely, but there is an anterior mediastinal mass. Dr. Shilpi, okay. Thank you really, for taking your time and joining our webinar today as one of the expert here. So, do you agree that all the pathologists should also possess overall interest in medical knowledge and then medical various specialties along with your primary specialty, that is histopathology?
Yes, sir. Many times we have a knowledge of different fields because most of the time diagnoses are multidisciplinary approach, not on the basis on the histopathology. You have to see the other reports like in pleural fluid or pleural biopsies. You cannot diagnose lymphoma in pleural biopsy. Like if because many of time tuberculosis also picture gives like lymphocytic fluid and some lymphocytic infiltration in pleural biopsy with tuberculosis and then can mimic. So you have to take the overall knowledge of what is the CBC finding, what are the hematological findings, what are the clinical presentation, and what are your pulmonologist or hematologist colleagues are searching for. So you have to take the thorough knowledge. You cannot.
So what are all particularly I feel when we talk to our histopathologists, we give a lot of history. The only fear what we have is whatever we say, example, clinically, madam, there was an evening rise of temperature. So I may be thinking that clinically it is a tuberculosis lymph node or tuberculosis lung biopsy. So do we still, need to add this clinical diagnosis, or you want to see the slides first and then take the clinical history later on? What is your take on this?
Sir, I think when we see the biopsy, we surely not biased with the clinical history. First, we see the diagnosis because most of the time in tuberculosis, the biopsy is necrotic. So when this is necrotic, when we are not seeing the well-formed epithelial granulomas and these AFB not positive, then we have to search for history. That if there is history and in biopsy we are find the necrosis, caseous necrosis. So then we can see that this is the case of can be tuberculosis. And if the necrosis is fibrinoid type and giant cell are there but necrosis is not there, non-caseating granulomas, then it can be type of sarcoid also. Then we have to correlate with the history.
So what Dr. Shilpi is telling to all the audience who are listening is, histopathologists are unstoppable, unshakable. So by providing even clinical details, you cannot change the report, right?
But sir, I want to share one thing.
Please.
When you are filling the requisition form, then you have to clearly mention that this is the transbronchial biopsy, that it is endobronchial biopsy, or it is pleural biopsy, or it is EBUS. And like this, if it is a EBUS sample, and we are seeing a lot of bronchial epithelial cells in there, so this is contamination. And if you have not mentioned that is EBUS, then
so you will mention that improve your EBUS skills, right? Good, excellent. Thank you. Again, let me share the slides back. One moment. Right. So we were at discussing at this CT. Now, Dr. Nikhil and then Dr. Shilpi was clearly mentioning, okay, they need a biopsy. Not only radiology is enough to diagnose this case, what is happening. But as we were discussing about a type 2 failure case, very likely this can be some tumor which can potentially cause a type 2 failure, neuromuscular weakness as a result of paraneoplastic syndrome. So most likely this will be a thymoma to my best of knowledge. And then what are the various, Dr. Gunjan, please, right. So what are the various paraneoplastic syndromes that can be associated with such cases?
Sir, here we can think or categorize the paraneoplastic syndromes in two categories. Either it can be neurological or non-neurological. Coming to the neurological part, we can think of myasthenia gravis, myositis, neuromyotonia, encephalitis, subacute hearing loss, autonomic neuropathy. And then we have non-neurological causes like hypercalcemia, intestinal pseudo-obstruction, pemphigus, alopecia, vitiligo, pure red cell aplasia, and hypogammaglobulinemia.
Right.
We can think in these two ways over here.
So imagine, so we don't have the knowledge of neurology, and then we don't have a knowledge of radiological assessment in such cases. People or physicians still continue to treat this as a asthma exacerbation and type 2 failure, and then ultimately patient is not going to improve at all. So that's why it is very, very important to have the thorough radiological knowledge, and if at all, if you don't have enough knowledge, no problem, pick up a phone and then talk to Dr. Nikhil. Dr. Nikhil, this is nowadays the social media has made our job very easy. Put the X-ray and put the CT across to Dr. Nikhil, who is from Ludhiana, and then he is going to report us, this is probably thymoma what you are dealing with. So life is so simple, and then the only thing is we have to take the help of our colleagues as and when required. And so, Dr. Chandrakant, how to reduce the number of hospital admissions from here on? Okay, we have a diagnosis now of myasthenia gravis, likely, and how to take it further.
As we diagnosed the patient, not a simple asthma, but complicated by the myasthenia gravis. And because of that, she had a muscle weakness and type 2 respiratory failure. To prevent that, basically, we need to treat the underlying cause, that is myasthenia gravis. We can treat with a drug like pyridostigmine. And eventually, when the muscle power improves, gradually her breathing capacity also will improve. And the hyperventilation part will come down, and the type 2 respiratory failure part also will resolve. This is one thing. And we need to even, obviously, we have to optimize the asthma. If you control our myasthenia gravis part, I think the recurrent hospitalization for type 2 respiratory failures will get resolved. And if the patient is operable, I think better to operate for the myasthenia, this thymoma part. In case if some myasthenia gravis without thymoma or not control on the medical management, we can consider for the NIV, long-term home NIV, also one of the options for chronic type 2 respiratory failure because of any neuromuscular disease patient.
Right. So I would like to request Dr. Vishali to add how to take it further for a surgery, because already she is requiring mechanical ventilation. Can I rush and take the opinion of thoracic surgeon and then take her to OT, or there is anything else that you want to add here, Dr. Vishali?
So see, now we are dealing with an asthma which we possibly labeled uncontrolled, which was possibly not uncontrolled, and there was this element of the myasthenia gravis which was in play. In such a scenario, and this is like, where she's requiring an invasive ventilation, this becomes a myasthenic crisis, which is ideally to be dealt with immunoglobulin therapy, or you have to go in for a plasma exchange in such cases after you rule out infection completely. Okay, once she's stabilized, irrespective of her having, first you stabilize, her as a person, because she's been quite stable on the ventilator. I've assumed that she's undergone a biopsy. We've assumed that she's done the anti-mask and the ACHR antibodies, which have their own levels of sensitivity.
Yeah, interest of time, we have short on there. Right.
Yeah. So we've assumed. So in that case, generally, even if you do not see this kind of a tumor, it is said that go ahead and remove whatever tissue is there in the mediastinum. So after optimizing, there's no need for doing an emergency surgery. You optimize and then take up the individual for a thymectomy, which is necessary.
Right. Fantastic. And then, despite example, I just like like to ask you, Vrishali, as Dr. Chandrakant was mentioning, imagine there was no tumor in this case, and then patient is having recurrent or probably NIV dependence or BiPAP dependence to maintain her ventilation. So in such scenario, do you ask the same patient to continue with a BiPAP or AVAPs or IVAPs kind of thing at home, or you would love to tracheostomize this patient and then add on BiPAP? What is your take on this?
A tracheostomy can come on later. If they're just maintaining on a non-invasive ventilator, there's no need to go in for tracheostomy. So we are contemplating that there is a neuromuscular disease which is not treatable and it's going to be progressing. But eventually tracheostomy is going to come down the line. So that is what the counseling part comes in. We have to tell them what they're going to be facing in the future.
Right. And anything, Dr. Gunjan, you want to add here? Dr. Gunjan?
Sir, already she has given us a good management part. We can follow the same.
Right, excellent. So coming to the next case, 33-year-old, and I'm sorry, Dr. Shilpi, you want to add anything to the above case, and how does you differentiate the tumors of mediastinum? Any broad lines, broad way that you want to add here?
get mediastinal masses according to their position, anterior, posterior, and middle. And first we have to differentiate according to their position. Then the main tumors located in mediastinum are lymphomas, and then some metastatic lesion if lung is the main tumor. So first we have to always take the history of any lung mass. Many a time we get the biopsy from mediastinal mass and we don't have the report of CT chest or in hand, and there's some metastatic and then thymoma.
Thank you, Dr. Shilpi. Let's move on to the next case. A 33-year-old thin-built female patient presented with progressive dyspnea since past 10 days, which is aggravated by left lateral position. There is a history of fever on and off present for the past 15 days. There is significant weight loss, that is 6 kgs in past 1 month. On examination, there is a distended abdomen. Vitals are stable with saturation of 96% on room air, and breath sounds are reduced on right side with stony dullness to purcus, and there is a tracheal shift to left side. Dr. Gunjan?
Probably it could be a case of mixed syndrome.
So there is a fever. Okay, there is a fever here. Okay, anything else? Okay, Vishali, please.
See, MIGS is more common amongst the postmenopausal women. It's really uncommon amongst younger people. I think with an Indian scenario, only by the distended abdomen, that is, she have a ascites alone. I mean, I will always, for a 33-year-old, tuberculosis, connective tissue disease, so polycirrhosis of any kind is something which I'll be looking for. And obviously, we'll go ahead with, finding out, I mean, a pleural tap, or what is the reason for the distended abdomen? Is it, on examination, is it HS megaly? Are the lymph nodes? Is there some kind of mass? There's so many things which will come into picture. You need to give us a little more.
Right. So there was a fever as well, on and off fever. So we should also think of infectious etiology and then connective tissue disease etiology as well, because both of them, they classically presented with, fever. And engage, as you rightly said, before jumping onto me, okay, we should think of, other differentials. And we have, and now the ultrasound revealed a mobile semi-solid right adnexal tumor in the lower abdominal quadrants, almost 15 into 14 centimeter, and there was an ascites as well. And chest X-ray showing moderate right side pleural effusion. And now, how to move on further, Dr. Chandrakant?
Now, if you see here, there's a classical presentation of mixed syndrome. We have the ovarian tumor here in the ultrasound, and the presence of the pleural effusion and the ascites.
Right.
And this is a classical case of the mixed syndrome. Anyhow, we should do the analysis, as we saw this patient had sometimes two pathologies also possible: ovarian tumor plus tuberculosis. So pleural fluid analysis is important, because the patient had a history of fever also, weight loss also, and the unilateral effusion. So we should rule out the tuberculosis.
Right.
And ascites also sometimes can present the tuberculosis. We have the difference of TB and the mixed syndrome here.
Right.
And sometimes in the malignant effusion also, or malignant ascites also can present like this.
Right.
And basically, I think we should have if the patient is stable, we should have the biopsy of the that's from ovarian tumor.
Right. Next, so definitive diagnostic criteria of Meeks syndrome, it says very clearly permanent resolution of ascites and effusion following the tumor removal, and HP of the mass should be benign, and returning of elevated CA-125 levels following surgery. Okay, the first two are really compulsory. And what is pseudomix? Vishali?
I think so. Basically, mixed syndrome was, I think it was a fibroma. It is a fibroma of the ovary, or you have the Brenner tumor. If there are other tumors, it is known as a pseudomix. kind of
not meeting the above two criteria, that is also one of the things we can take up.
Gagan?
And not meeting the above two criteria as to of that of mixed syndrome, what you in the previous slide
So
showed
if
us.
the tumor doesn't, the effusion doesn't subside after surgical removal, then we call it as a pseudomix essentially. Right. Thank you both, Dr. Vishali and Dr. Gagan. And one important case now to discuss, a 31-year-old female, known case of hypertension and dyslipidemia. At the age of just 31, she had hypertension and dyslipidemia, G3, para2 and A2, 2 history of abortions. Okay, please note. And with 18 weeks of gestation now, and there was a history of DVT in last pregnancy, now presented to ER with severe lower abdominal pain worsening over the last 24 hours. There was a vaginal bleeding soaked through 2 pads in the last few hours, high-grade fevers. On examination, tachypnea, tachycardia, and the borderline pressures. The lab value shows leukocytosis, total leukocyte count 18,000, neutrophil predominant, anemia, thrombocytopenia, prolonged PT and APTT, increased fibrin degradation projects, and ultrasound in ER showed significant uterine contents and consistent with incomplete septic abortion, fluid collection noted in the pelvic cavity. So how to take it forward, Dr. Vishali? What is this pattern looks like?
This looks like a bad obstetric history with a bleeding tendency, and with your DIC kind of a picture, you will think in terms of an APLA, young female. Okay.
Young female, right.
Yes.
And more importantly, if you see young female with hypertension and also dyslipidemia, this is very, very unusual combination. And then abortions, that also favors, probably we are dealing with APLA.
Yeah. So basically, accelerated accelerated atherosclerosis is quite common with these kind of individuals. Yes.
Right. So
it is APLA most likely.
Most likely is APLA.
Dr. Gagan, right. There are various criteria for APLA. So what is that you depend most on, and how to use it in our clinical scenarios?
Actually, we have 2 criteria over here, SAPRO criteria and Sydney criteria. And most often we go for this lupus anticoagulants, anticardiolipin antibodies, and anti-2 beta-2 GPI antibodies. And we have to screen and miss the patients 2 or more occasions. These markers should be present on 2 or more occasions and at least 6 weeks apart. Meeting any 2 out of 3 criteria is in favor of APLA. That's how basically we screen the patients and we look for all these things.
So the gap score also, I think you mentioned, and then which is we often use, and it is easy to use in our clinical settings. Do you agree?
Yes, sir, agreed.
Yeah. Dr. Tarke, you want to add anything here in APLA?
APLA, basically, some antibodies are important. Beta-2 microglobulin and this cardiolipin antibody. And this ideally we should have to repeat after a few weeks also for confirmation, especially more than 2 occasions, at least 12 weeks apart.
Right.
Then this fits into the criteria of the APLA syndrome.
Right. It is, my dear friends who are all listening, it is very, very important to suspect. So already this young lady has got 2 abortions already with the hypertension and then dyslipidemia as a risk factors. In such scenario, it is very important to address the underlying etiology by diagnosing properly, and then coming to choice of anticoagulant in this case. Dr. Vishali, what is your take?
So it is very clear that you have to give the coumarin drugs, derivatives, or vitamin K antagonists are the standard of care. And this lady, since now she's already the delivery's happened, and otherwise pre-delivery you give them an aspirin once they are in that zone. Then heparin is what we give in the first 3 weeks till the time of organogenesis. Then eventually,
And now, thank you, Vishali. And then now, may I take the opinion of Dr. Shilpi. Dr. Shilpi, when do you how to send. Say me, Chandrakant, do quite often the cryolung biopsies. And then what is your take? And then how do you expect the sample to reach you, and how to segregate?
Okay. Nice. It is a very important question because most of the time in certain our medical colleges setting or in hospitals, some junior consultants or junior residents are also there. So
Right.
thing, when you send the sample should be in the formalin. And if you want the frozen section of or immediate finding of any case, rose finding like, then you have to send sample in a normal saline or in the plain vial. But if you for histopathology, you have to send sample in formalin because most of the time when we receive sample in the night time or in the emergency use, most of the time sample come in normal saline, and in
Right.
the whole night the sample will go waste, and you can see that tissue is the main issue in our diagnosis. So you have to send sample always in formalin, duly filled form, requisition form, and what spatial stain you want. Like for fungal stain, we can GMS and pass stain. For these JN stain, for AFB stain, and then if this is the case of transplant, lung transplant, then you have to mention it on the form because we have to apply the CMV CD4 count, and if there is a tumor, then we have to send the sample for IHC and for the further molecular testing like for gene panels also. So send the sample in formalin. It is must.
And Dr. Chandrakant, you want to add anything? So when we take the lung biopsies or EBUS sample, so apart from formalin, what other measures that we should take so that because these are the procedures we cannot repeat again and again.
Correct.
And we should preserve the sample so that even for future analysis, it should be there in a good shape. Yeah, please.
Yeah, especially if you take the ball and majority of the times we send the routine sample for all the stains and culture for bacteria, fungus, and tuberculosis, including gene expert. But some cases, if you are suspecting the fungi, we have to send for the galactomannan. And in case, yes, the patient is immunosuppressant, we have to suspect for the PCP, nocardia stain, quinoa stain. That's why we should preserve the sample. And especially if you are suspecting EBUS samples, and if you are suspecting the tuberculosis, definitely we should take in the normal saline also for microbiological purpose, because if you are doing the AFB culture, so we have to send in the normal saline itself, and for gene expert also. Microbiology samples in the saline, and obviously madam said for histopathology we have to send in the formalin. And also we should prepare some slides which should be, some of the sites should be air dried and some of the sites should be alcohol fixed. For I think that will be helpful for the pathologist from all the angles.
Dr. Shilpi, just to add, what additionally, because while you were talking, I got a information that there is an ER1 patient who had a pneumothorax. So I was focusing on that. I'm sorry for that. So how soon we have to fix it in formalin?
Sir, if you want the adequacy sample,
Right.
like in EBA sample, we perform rapid on-site cytology.
Right.
So then we make 2 slides from each sample, one wet fixed and one dry for GIMSA and PAP staining, and then immediately make 2 slides and then immediately transfer the tissue into the formalin.
Right.
And if the sample is granulomatous, then we take one sample in, and sir rightly said, one sample in normal saline and other in for formalin. And if it is tumor, then we take whole sample, it should be in formalin.
Thank you. Thank you so much. Similarly, I would like to request Dr. Nikhil, what Dr. Nikhil expects a pulmonologist to write to him so that the perfect CT scan is made. It is not, I remember the general practice, what has happened in nowadays is, if you don't know anything, even if X-ray is normal, write a CT scan. This is not what we expect from the clinicians. So sometimes when there is an emergency, so we write CT pulmonary angio, because you are going to look at the parenchyma, you are going to look at the mediastinum, you are going to look at the vasculature, you are going to rule out the pulmonary embolism, everything. So probably across the globe, there are more often the CT pulmonary angiograms are done for unnecessary reasons than for necessary reasons. And I request now Dr. Nikhil to throw some light that what he expects us to tell to the patient and to the CT technician or radiology colleague, so that we get the adequate scan, so that we don't repeat the CT scan, to decrease the cost and also to avoid unnecessary radiation.
Yes, sir. First of all this is related to history of the patient. If you are suspecting a tumor, then a contrast CT should be enough. If you are suspecting infective etiology, then mostly HRCT almost does the job in 90% of cases. And if the patient comes with hemopsis, then we should go for a multimodality CT. That is, we should have pulmonary as well as bronchial angio included in addition to HRCT chest. So history is important. And if you are suspecting other things, like you are suspecting a pulmonary embolism, so ultrasound of the lower limbs to rule out DVT should also be done.
Right.
The first line can be done bedside.
Right.
So,
thank you, Dr. Nikhil. Here, so the question is especially to Dr. Murali from Dr. Kiran. Can you please throw some light on excessive dynamic airway collapse?
I mean, I can't throw light on it, but I can think about it. Where do you throw light from? Yeah.
Right.
So
probably light means looking through bronchoscope. Looking through bronchoscope and diagnosing EDAC.
I think I'm so sorry. I meant to say that you suspect an EDAC. Even as I think one of the things in asthma which we have are thinking of an asthma which is poorly controlled your wheezing. An elderly individual can think in terms of an excessive dynamic airway collapse. And so many times these patients are not true asthmatics, but even in an asthma, it can be an add-on thing. So about excessive dynamic airway collapses, I think most of the time what we do is a PEP device which can work for these individuals. And you have more of the posterior wall which just collapses inside instead of actually keeping it open in this. And in very rare cases, CPAP machines for most people where there's quite severe symptoms, and in some rare cases, you can go ahead with stenting of the airway to mitigate the patient of whatever problems he or she is having because of the EDAC.
Right. When I was with Mercy, when I was at Mercy with our Hervé Duttau sir and Astul Philippe sir, so they have published good amount of data. They have done for one case as well while I was there, way back in 2013-14, I believe. So laser can play a very good role. They give a linear cuts in the posterior wall so that after fibrosing, the EDAC gets better. That's one of the good modality. And Dr. Hervé Duttau has good number of cases and good publications on this, Dr. Kiran. Now, other gentleman, Dr. Bishwas Sharma from Telangana, Hyderabad. So, now I take it to Dr. Gagan. So, what are the antihypertensive drugs that should be avoided in patients with anti-tubercular drugs? This is a perfect bouncer, man.
I can take this if
let's see what Gagan has.
No, ma'am will take it. As per, there's nothing to avoid any specific such drugs to be avoided in anti-tuberculosis patients.
Probably to combine, to permutate and tell So probably AC inhibitor should be avoided so that it can reduce the cough, like that.
No.
That are side effects that we have to monitor on daily to daily basis, but no such contraindications exist with anti-tuberculosis drugs and antihypertensive drugs.
Absolutely. What sir wants to probably ask is because I had my own teacher who I was treating, and his blood pressure. So he was antihypertensive. The moment I put him on AKT, his blood pressure started shooting because rifampicin is okay, and rifampicin particularly does it for calcium channel blockers. It also does it for beta blockers and diuretics, and you might have to put up the patient's antihypertensive therapy during the patient being on AKT. But while I was ruling out other things, but this is, rifampicin is the drug which is metabolizing. So, I mean, a life case for me and my teacher. So, obviously, I had read it.
Excellent. I learned a beautiful point today from Vishali. Right. Chandrakant, you have anything to add there?
And initially, I also thought like that, like sir said, I think there is no interaction between ATT and this thing.
Right.
But as I said beautifully, we had to monitor for this blood pressure, rifampicin interactions. Yes.
Right. And our good friend, Dr. Tridip Chatterjee from Mumbai, okay, he says common side effect of Brilinta is breathlessness. What do you do? And the second question from Dr. Tridip again is, for adequate transbronchial lung biopsy, how much alveolar tissue should be there, or it will just be a bronchial biopsy and not TBLB? So the first question to Dr. Vishali again. Okay, common side effect of Brilinta is dyspnea, and what to do?
I am really not aware about this side effect, frankly. Okay. And if a person is complaining, see, first of all, it has to be a rule out thing that you are labeling this is because of Brilinta and not because of the primary condition or so many and so other things. And in such cases, we do switch if you've chosen. But like I said, I have not come across this. I mean, Chandrakant sir and Dr. Gunjan Gagan can, shed some light on this. But then they do go on to the next line. So they do go on to clopidogrel for these individuals after explaining the risk. But like I said, I've barely seen this or even heard about Brilinta giving rise to breathlessness. As I said, after ruling out, there's something like, again, I prefer to go the anxiolytic way many of the times. And I think that can be a bridge if at all Brilinta causes breathlessness.
Yeah, and most often what it is it subsides over time, Dr. Vishali. See, what literature says that if the patient continues to have, probably he is not a right candidate for Brilinta, particularly when he have breathlessness as a symptom. Then what we can do is we can change the antiplatelet and use different antiplatelet. That's what it is recommended. And Dr. Tridip, I hope I have answered. Yeah,
you have come across such cases. I haven't.
No, it's only literature. Literature, very rare. And for you, Dr. Vishali now, and also to Dr. Shilpi later on. So the second question from Tridip which what is the adequacy for transbronchial lung biopsy? How much alveolar tissue should be there to report it as adequate?
Yes, actually, most of the time.
One moment, Dr. Shilpi, let Dr. Vishali
comment
answer,
first,
and then we will come there.
Put into a
because first we have to take the sample by Vishali and then submit to pathologist.
Okay.
Right.
So I think I think whatever a pulmonologist takes is sufficient. Because I've never drilled into this thing that how much alveolar tissue has to be around.
No,
but
probably Tridip was asking. Tridip was asking how many samples do we need to attempt cryobiopsy?
Yeah. So what in that there are recommendations are very clear. You have to take 4 to 6 biopsies, but generally, if you are going from the proper area, I think 2 biopsies also suffice. Also because we are very good pathologists.
With the advent of cryo, even 2 bits is good enough, right?
Yeah. And with a very good pathologist, those 2 bits are definitely good.
Like Dr. Shilpi ma'am is there, then even probably if we get one bit also, it may be sufficient. Over to Dr. Shilpi.
If it picks up that tissue, yes, but yes, ma'am, I would really like to know how much alveolar tissue.
many of the times you mention that it is the TBLB sample, but most of the time, if you send the 5 bits, out of 5 bits, 3 are bronchial tissue and 1 or 2 are lung tissue. So that is the scenario. And if granuloma or malignancy is there, then you can, yes, you can definitely say on 1 to 2 bits. But for interstitial lung disease, like interstitial lung disease, you can also inform the cryobiopsy. But you want the ILD diagnosis on the TBLB. So for ILD or interstitial lung disease, some transplant type of thing, you have to take 5 bits, at least 5 bits of lung tissue, and most of the time on microscopy, more than 100 alveoli. So to take that it is interstitial inflammation, perivascular lymphocytic infiltration, or something else. So 5 bits and 100 alveoli, I think.
So I want to say one important thing, if you permit, ma'am.
Yes.
See, this is called indoor bias. Huh? Indoor bias. Right. So many of them, now let me be honest, the same scenario was existing probably a decade back. So there were, improper technique is being practiced, and then the way the transbronchial lung biopsy and cryobiopsy was not standardized in those days. The pulmonologist used to submit you such bronchial epithelium as almost 60% of the sample, only 20% or 30% of sample is alveolar tissue. But now no longer. Majority of the centers across India, well-trained interventional pulmonologists are there, and the protocol with which we sample the lung tissue is pretty much standardized, and now we are giving very good tissue. Hope Dr. Chandrakant, Gagan, and then Dr. Vishali also agrees to me. Right.
Yeah.
And there is a question here from Dr. Jyoti from Karnataka, Bengaluru. What test we can do when patient is having ischemic heart disease with ILD and having breathlessness, DLCO, 6-minute walk test, or any other kid in the block? Chandrakant.
So DLCO 6-minute walk test majority we do for the respiratory cases, for example, COPD, ILD, pulmonary hypertension. But if you want to differentiate between cardiac and respiratory, I think apart from this, we can do the 2D echo and other cardiac evaluation. And particularly if new kid, I think the doctor is asking, we can think of CPET, cardiopulmonary exercise testing. If the patient is stable enough, we can do this testing. And there are enough number of parameters such as anaerobic threshold, peak oxygen consumption, and ventilatory efficiency for carbon dioxide.
VO2 max.
All these parameters we can study VO2 max, and we can fairly differentiate whether the deterioration of this patient or breathlessness is more because of the ILD or more because of the cardiac disease.
Thank you.
Sir, actually, when we are in emergency with such cases, our idea should be clear whether it is due to cardiac origin or it is due to respiratory origin. Once we have done the ECG and we can rule out the things of going in favor of cardiac or respiratory, and then we can move on forward, as sir has rightly said, over 6-minute walk test or DLC or anything other than.
And Dr. Vrishali was rightly mentioning, Dr. Gagan, that pro-BNP in such scenario will be very, very highly useful,
especially
apart from the regular ECG, echo, and all those things, particularly in emergency.
Actually, sir, anti-pro-BNP would be more sensitive and more better option for that. But then we have certain cardiac failures to look for. We have in raised JBP and other shock patterns, shock symptoms that we can think of doing anti-pro-BNP and other things. Otherwise, what we have in ECG is sufficient to rule out cardiac and the respiratory origin test.
Right.
Then we have grading.
What I meant was more towards
NYHA grading is also quite good in evaluating the history part.
Yeah,
Right.
true. But if you do not have the raised JVP and you just have crepitations, which can be because of the ILD also, and which can be because of the cardiac cause, that is the time I said where you go in for the hematological thing, which you can look out for, lab investigation.
Oh,
Yes, ma'am.
9:39 is the time now. And the Krishna Anna posted in the group saying that there were 1,138 logins across India. And amazing presentation complementing both Gagan and Dr. Vrishali by Krishna Anna. And we'll now it is 9:40. I'll try to sum up in probably in another 10 minutes. There are few important questions that are pending here. Let me run through and then please be very crisp in answering. And when it is indicated in a patient with congestive cardiac failure, so when it is indicated, is it indicated to do thoracensis for pleural effusion in case of heart failure? And what is the role of, as we discussed, the role of NT-proBNP to rule in the effusion is secondary to CHF in case of effusion, which is not meeting the criteria of Light's criteria for transdate. Over to Dr. Brushali.
I'm sorry, I was not attentive. I'm just going through some disk.
No. So, a known case of cardiac failure present for you in emergency, having breathlessness. So generally we attempt to do diuresis and then stabilize with NIV. That is the first line of management, oxygen support and all those things.
Yes.
But are there some cases you go ahead and put a needle and then try to see this is not transdate, this must be something else causing the trouble. What are those scenarios?
So generally, if you have only a left-sided effusion and a massive one at that, though by definition, 20% can be only left-sided, and it is not responding to the diuretic therapy, definitely I will go in and put in a needle and aspirate and then go according to the SAG or the gradient criteria, because the patient will already be on diuretics. If there is anything, see, everything boils down to a clinical history. And like I said, we were examining. So anything in the history which is pointing that, no, this is not a cardiac cachexia, these people will also have cardiac cachexia, and it warrants a look for a tuberculosis, or maybe the individual is an alcoholic cardiomyopathy and possibly has an abdominal pain where I won't think that the left-sided effusion is because of a pancreatic reason, or there is a possible malignancy on cards. That is the time I will put in a needle. But so this is generally how we'll do it. Yeah.
Right. So what you say is patient who is not responding to the first line therapy, and then despite that showing other symptoms, the disparity in size of effusion and pleuritic chest pain may say that probably there may be underlying infection, febrile, and there was no cardiomegaly. These are the things, my dear friends, where you may need to move one step ahead and then put the needle in these patients. Now, I would request, there is this particular question to Dr. Gagan. So what is the impact of obesity on respiratory mechanics? Can you please tell briefly?
The impact of obesity on respiratory mechanics.
Yes.
Actually, obesity is always a risk factor for exacerbation of any sort of respiratory tract infection, pulmonary, vascular diseases, and ventilatory failure. Weight loss is a key treatment modality for improving respiratory function in patients with raised BMI. The prevalence of obesity and therefore obesity-related respiratory complications is increasing, and it needs to be observed closely by all the healthcare professionals. The effects of the obesity on respiratory system can be explained by the physical load that additional central adipose tissue has on the system and a systemic inflammatory response that is induced with increased BMI. It causes reduced lung volumes and airway caliber and increased airway hyperresponsiveness. So we need to modify all those things in treating obesity, and decreasing keeping in control the BMI part is essential for all these things.
Dr. Chandrakant, can you please add something, how to manage in such scenario? Obesity as a metabolic syndrome, when it presents, how do you want to holistically address these issues? What are the various things as a pulmonologist and as a general physician as well? Overall, holistic approach, what you would like to have?
As we discussed, obesity has a significant effect on the respiratory symptom. There will be muscle weakness, and even in morbid obesity, the decrease in the lung capacity, and the obesity, hyperventilation, and obstructive sleep apnea. And a significant number of the patient can have the diastolic dysfunction, even pulmonary hypertension because of the nocturnal hypoxemia. Basically, we should evaluate for the obesity hyperventilation syndrome. We should do the sleep study to rule out the sleep apnea. We can advise for the CPAP. We can advise for the optimize weight reduction and to get the optimal weight.
Thank you. Thank you for, that's a brilliant summary and management of when there is obesity. We must address all the associated comorbidities to treat this metabolic syndrome properly. And all beautiful things, great things comes to end. Okay, we have to accept that. It was a brilliant 1.5 hour session, 1 hour 45 minutes session so far we have had. I'm absolutely, felt that did I started only 10 minutes back? So time flew like anything. Now, I would like to take 1 or 2 liner summaries from each one of you to conclude this session. And first, our guest, Dr. Gagan, please. What is that you want to say as a conclusion message for what is beyond pulmonology for pulmonologists?
Beyond pulmonology for pulmonologists, I am in between pulmonologists. Right. It was a wonderful to be a part of this seminar, and I enjoyed the company of all the pulmonologists sitting over here, and it was a lovely meeting over here. And we also had a great information about the topic that we covered today, pulmonary manifestation of systemic illness or systemic illness of pulmonary medicine, vice versa. It was just wonderful talk, and we have done the questions very well today.
Thank you. Thank you, Gagan bhai. Shilpi ma'am.
Thank you, sir.
Yes, it is a wonderful seminar, sir. I want, as your procedures are very prestigious and sample is very precious, so I want spare few minutes to fill the form and what test you want from our and properly send the sample to the lab.
We are lazy buggers, ma'am. We would love to talk to you rather than filling the form. We will talk to you and pass on the information. Dr. Nikhil.
Sir, I would like to just stress on 2-3 things. One is a detailed clinical history, any systemic examination findings, any past history. We should discuss in detail with the radiologist because many diseases show overlap in imaging finding. And also keep an open mind about the diagnosis.
Right. Thank you. Thank you, Dr. Nikhil. Chandrakant, bye.
As Dr. Nikhil told, for any patient, I think we should think holistically, means entire from head to toe examination and detailed history is very much important. Just to give a small example, we had a recently patient of ARDS and nothing we were able to get. We found small ishar over this thigh area and this turned out to be some rickettsial typhus disease. That's the reason is history, physiological examination is very much important, which can avoid any major investigation also we can avoid. And we should not look through telescopic view of lungs only. We should see towards heart, liver, kidneys, and entire brain. Everything we should see, including neuromuscular diseases. I think that is the message comes out of this webinar. Is not only we should see the lungs, we should see the entire body to diagnose and treat the patient.
Dr. Vishali.
Yeah, I think everyone has said the right thing. Like Shilpi madam said that, so each one I'll say that Shilpi madam said that the things are to be properly labeled and ensured to be sent. So Shilpi madam, I confirm to you, and actually I do not allow my residents to fill it. I do it myself. I don't even allow the mama to hold the sample. Over this because we've had this. My colleague had this problem where the lady in coming, she cleaned up everything. She threw the sample right through the basin. And we were left hunting for where the sample is. Regarding Dr. Gagan, Nikhil's input, it is very imperative that we tell our radiologists what we are expecting and what is being seen on the clinical side before they start reporting a scan. So in that, I'll just do a short story where some patient was unable to be weaned off a ventilator. A 6-month postpartum lady was not being weaned off the ventilator, and those people just came to me with a report which said that there is a minimal subsegmental pneumonia in the basis. I saw this and I said, ask them 2 questions. They said, it's 12 days and she's not being able to be weaned. I said, I'll just ask 2 questions. Do you think her eyes droop? They said, no. I said, show me the scan. They get me the scan the next day. All I do is directly look into the mediastinum and I see a mass which has been completely not reported. So I think, and then I asked them, then do you have a blood gas which is showing a CO2 on the higher side? So if you have a respiratory where there's nothing why should this person not be weaned off? And that is how our 1 + 1 is actually 4 in some cases. And most importantly, I said that head to toe. And I think we as doctors, we have this inherent knack of understanding many things. So I talk to each one, be the neurologist, be the cardiologist, be the gastroenterologist, and I keep on learning from every. I read out their notes and I take the small pointers and thing which helps me in my next patient. So a holistic approach. I am a pulmonologist, does not work. My basic selection has been, MBBS, where I've learned all the systems. And it is imperative that I see all the systems where I do not understand because I'm not reading the latest. I involve the right kind of people.
So what has happened is, I thought of telling all these things and Vrushali has told now. What is there for me to tell? Nothing. So except saying good night. But before saying good night, I'm sure Krishna Anna openly admitted that pulmonology, beyond pulmonology for pulmonologists, will have further series of, interesting cases and discussions so that we can discuss so much. The subject is very, very vast and we can discuss hundreds of cases in this forum. I'm sure we will do that. This is only Bahubali number 1. Bahubali 2, Bahubali Z is also awaited. So with this, and I thoroughly enjoyed today, learned a lot from Vrushali, from Chandrakant, from Dr. Shilpi, Gagan Bhai, Nikhil Bhai, everyone. So I sincerely thank Zuventus people for sponsoring, and then the backbone, the technical team, our Bijal, Vinod, Amit and others, our core webinar team, that is Dr. Shivani, Dr. Atri, Dr. Kirat, and all beautiful souls working day and night relentlessly. Now we have reached 4 years and 4 months. Many more years to go, many more wonderful topics to cover. We will see you again soon in next Thursday, Guruvar ke Raat, Guru ke Saath. The concept which was 4 years back launched, now it has transformed into today Beyond Pulmonology for Pulmonologists. Thank you one and all. Good night.
Thank you, sir. Good night. Good night, sir. Good night all.